Hello, my name is Vishnu Naidu. I am currently an ST4 radiology registrar here at the Royal Free Hospital in London. Today's lecture will be on abdominal imaging, and I hope you gain a lot from this. I have three main learning objectives today. The first is to gain an understanding of the different imaging modalities available to investigate the GI system in the radiology department. The second is to be able to recognize normal anatomical structures in these different imaging modalities deployed. And the last is to begin to understand common pathology within the GI system. I know year one is about learning normal physiology and normal anatomy, but I think it will be nice to introduce you to certain pathology which will make all of the anatomy and physiology knowledge that you have make more sense. So X-rays form a fundamental part of imaging in the radiology department. It is used for imaging the abdomen in acute situations, but also in the setting of fluoroscopic contrast swallows. In acute situations, we use both plain radiographs or kind of plain films, as well as CT. Essentially, how an X-ray is produced, so we have an X-ray tube which emits X-rays in a controlled fashion. These X-rays are directed towards a patient, and the X-rays pass through the patient onto the other side, whereby we have a detector. X-rays that pass through a patient are either absorbed by high-density things like bone, or are able to go through and reach the detector when they go through low-density substances like air. And depending on the strength of radiation received, gives a different shade of grey. So air, for example, would look really black, as most of the X-rays have passed through the patient unimpeded. However, if these X-rays try to go through bone or metal, most of them are either reflected or absorbed, and so few of them reach the detector and they look white. So when X-rays meet the detector and create an image, there are 5 main densities that can be visualized. This is a direct result of how many X-rays have passed through the subject and arrived at the detector. For example, if all of the X-rays continue through and pass through air, most of them will arrive at the detector, and the area that represents air will be black. If the majority of X-rays are absorbed or deflected by bones, calcium, or metal, the area will not have as many X-rays and will be devoid of X-rays, and thus will be dense and white. Everything in between air and metal, for example, fat, soft tissue, fluid, muscle, will block and allow varying numbers of X-rays to pass through, and thus will be different shades of grey. So imaging from the mouth to the stomach is usually done under fluoroscopy in the radiology department. And what fluoroscopy is a method whereby continuous X-rays are taken in real time to image different parts of the body. So what I'd be doing is I'd be pressing a pedal in the fluoroscopy room, which continuously shines X-rays through patients whilst they swallow a liquid which is high in density. And if you remember, if a liquid is high in density, it will block X-rays from arriving at the detector and thus will appear white. And so we have a good contrast between normal anatomical structures, which will be either grey, some of the bones might be slightly white, but the material that they will be swallowing will be really, really dense and really, really white. So we can have good anatomical and mucosal detail as they swallow. And this is what we'll be imaging. So the oral contrast agents that we use generally are high density, and the main one that we use is called barium. So barium is a high density metallic liquid. It's white in colour and it comes in a Coke-sized can. And what these do, as I described, is they absorb X-rays and thus appear really bright on the images. Liquid barium is generally used when there's no suspicion of perforation, leak, or aspiration, as it can be toxic. So what aspiration is when when a patient's swallowing mechanism has become disrupted, in the sense that if they swallow, it doesn't go down the esophagus and it can go down the trachea and into the lungs. And in this setting, aspiration can be toxic. Perforation or leak is if there is a tear in the mucosa, for example, in the esophagus, and there's a risk of the barium leaking into the mediastinum or in the peritoneum, whereby it can be toxic. So in this instance, if there are any risks, then water-soluble contrast agents such as omnipaque can be used. And omnipaque is an agent that contains iodine. and this is not toxic if aspirated, or if there's a leak into the peritoneum or mediastinum. So I will now be talking about the anatomy of the lateral swallow. So what we can see here is a lateral view of the patient. So we are shining X-rays through the patient side on. So if you imagine the patient standing here, what we have is we have X-rays shining through that way and being detected by a detector behind the patient. So we have normal anatomical structures here. So first of all, everything as I mentioned previously, so all high density structures such as bone appear white as they block X-rays from being detected by the detector. And so we have the mandible, we have the maxilla, we have the cervical spine, so we have C2 here, which is the dens. We have C1 here, and then C3, 4, 5, 6, so forth. Gaseous structures don't allow, gaseous structures allow more X-rays to pass through, and so what you can see here is we can see the pharynx, we can see the trachea here, and that contains gas, and so most of the X-rays are passing through, and everything else around it, soft tissue, fat, muscle, appear different shades of grey. We have a few normal anatomical structures here. So we have the hard palate in the purple bracket, we have the soft palate in the blue bracket, and we have the base of the tongue, which is this indentation here in the red bracket, in the red arrow. Sorry. So we have more normal anatomical structures here. This is the hyoid bone in the blue arrow. We have the laryngeal vestibule with the yellow bracket. This green arrow just represents some air, so you can see a bit of black density here, a bit of air in the laryngeal ventricle between the true and false vocal cords, and that's quite difficult to appreciate on the lateral view. And the red bracket represents the proximal aspect of the trachea. After the initial oral phase whereby the contrast was in the patient's mouth, the patient is now swallowed and the contrast has entered the pharyngeal phase of swallow. We have normal anatomical structures here. What we have in the pink arrow is the normal epiglottic tilt. The orange arrow represents normal redundant pharyngeal mucosa. And we have the soft palate here, which prevents nasopharyngeal reflux. So the soft palate stops this barium or this contrast from going upwards. So after the patient is swallowed and the contrast has exited the mouth, so the oral and the pharyngeal phase and entered the esophagus more distally, we can see normal anatomical structures being outlined. So the superior red arrow here points to the base of the tongue, and the inferior red arrow here outlines the epiglottis. V represents the valleculae and P the piriform sinus. Division of the mesopharynx, which is above, and the hypopharynx is below, is demarcated by this dashed yellow line. And what we have here is different areas of the, different anatomical areas. So the red line here parallels the faint palatoglossal fold. The yellow line parallels the faint stylopharyngeus muscle, and the pink arrow points to the aryepiglottic fold. So swallowing is a complex act involving both involuntary and voluntary neural circuits and the coordination of multiple small muscles of the neck. Disruption of any part of the circuit may lead to decompensation from other structures. The patient may be unaware of the compensation, but our swallow examinations generally may reveal it. When any compensation methods have failed, this becomes decompensated and the patient may develop pathology such as aspiration. And aspiration, as I mentioned previously, means that the barium or the contrast material, which should be going down the food pipe, the esophagus, spills over into the esophagus, into the trachea. And so you'll see a picture where barium outlines or contrast material outlines the trachea, and I'll come on to that later. So what we have here is we have an AP and a lateral view. An AP view means basically this patient is standing face on to our X-ray source, which emits X-rays through the patient and is detected behind the patient. And a lateral view, as I mentioned previously, the patient is facing side on and we shine X-rays through the side of the patient, and it's detected behind the patient. Sorry. Good. So what we have here is we have the APN lateral views of the cervical esophagus. We'll move on next to see this is a slightly oblique view, whereby the patient is in between an AP and a lateral position, and we can see a good view of the thoracic esophagus here. So this thoracic esophagus, obviously we have normal anatomical structures behind it now. So what we have here is we have the thoracic vertebral bodies, which are high in density. We have multiple ribs. So these slightly horizontal ribs are actually the posterior ribs that we're seeing, and you can see it joining into the costovertebral transverse processes here. Costovertebral joint, sorry, here. These structures represent the clavicles, and we can see black density. Black density represents a structure that is filled with air, and in this context, it represents the lungs. Again, we have the heart border and the heart, which is slightly higher in density, and you can see it's more grey. And finally, we have the normal thoracic esophagus, which is very, very high in density, as we have swallowed high density metallic liquid. And what we have here is the gastroesophageal junction and the stomach. So this patient is standing up, and stomach normally can contain gas. And so what's happened here is that the high density and actually heavy contrast material is spilling into the stomach and outlining the stomach folds. But as the patient is standing up, air will always rise in physiological circumstances, and you can see that the stomach fundus is actually being outlined by air. So I hope that wasn't too quick, and I hope that all made sense. So what we see here is evidence of aspiration. So as I mentioned, aspiration in this context would represent liquid, or in this setting, contrast material entering an incorrect passage, and in this sense, it will be entering the trachea. So this is the trachea, and contrast material has actually, some of contrast material has actually passed down the normal route, which is the pharynx and then the esophagus, as you can see. But it has also abnormally gone anteriorly into the trachea. And so if this is a lateral view, as I said, and this is another lateral view. Well, actually, this is a bit more oblique, so the patient is in between an AP and lateral view. And so what we can see here is the trachea is very well outlined, as well as the bronchi and bronchioles. We can see the normal esophagus here going into the GOJ and into the stomach. And so this is quite bad, and this patient will require chest physiotherapy to prevent infections which may happen as a result. Again, this is another example of aspiration, and you can see that here we have the normal thoracic esophagus, and we have here abnormal trachea, which is and bronchi, bronchioles as well here, which have been outlined abnormally by contrast material. Good. On this AP or PA erect chest radiograph, what we have here, we have normal anatomical structures. So we have, first of all, the bones. We have the humeri here, clavicles. Oh, let me just put. So we have the humeri here, the clavicles. We have scapula. Yep, scapula. Scapula all the way here. And we have ribs. We also have the normal right heart border. We have the aortic knuckle. We have the left heart border. And what we have is we have normal lung, which is here, but then we have abnormal lung. So it looks like there is dense airspace opacification within the bilateral, medial, but also peripheral lower zones. And this is in keeping with aspiration of contrast material. So here we have an example of esophageal cancer. So the cancer is sitting around here. And what it's doing to the esophagus is it's causing tapering and narrowing. It looks like a string here. The esophagus proximal to this area is grossly dilated, and there is shouldering as we come into the area of the cancer. So radiographs of the abdomen can play a role as an adjunct or optional investigation in a patient with an acute abdomen. The reason is because it has poor sensitivity and specificity when compared to CT, so often patients go immediately for a CT. It can overestimate pathology such as bowel obstruction in these patients, but is very useful in assessing for free gas. Radiographs of the abdomen can be used effectively to evaluate foreign bodies, tubes and line positions, as well as in transit studies where a patient is given certain radiopaque objects to swallow and are imaged maybe 24 to 56 hours later to see how far these objects have gone from the stomach and which part of the bowel it is, whether it's in the rectum or whether it's obstructed slightly more proximally in the small bowel. So this is a normal abdominal radiograph. What normally happens is a patient is supine, which means that they're lying down flat on a bed. So this is our bed. And what happens is you have an X-ray source, which then shines X-rays through the patient, which then passes through the patient and onto a detector, which is behind the patient there. So we have a normal abdominal radiograph here. The first thing I would like to describe to you is laterality. So the opposite is true in radiograph. So the right of the patient is actually on the left of your screen, and the left of the patient is actually on the right of the screen. And so all of our normal anatomical structures that are on the right of the patient will be seen. We have our liver in purple. We have our right kidney in orange. We have our left kidney here. We have our spleen just tucked under the rib. And this is our rib here, just overlying. Other things that we can see are our vertebral bodies, the pedicles, spinous processes, and our transverse processes. We can also see muscle in this radiograph, and muscle is represented here. So the main muscle that we can see is our large psoas muscle. We can also see bowel loops, and actually some of these loops are fecalized. So fecalized mean containing feces. So we have here, we have our ascending colon, which contains loops of fecalized bowel material. We can also see that there is splenic flexure, descending colon. We've got a bit of transverse colon here as well. Another thing that we can see here is our slightly dense bladder. This dashed line here represents our ureter on the right, and the left side here represents our sacroiliac joint. Other things we can see is our normal pelvic bones, as well as the right humeral head, greater trochanter, and right femoral head, greater trochanter, and our neck of femur here. So this radiograph demonstrates bowel obstruction. So what we can see here is we have multiple loops of dilated small bowel, and the reason why you can tell they are small bowel is these lines that go all the way through the bowel loops, and these are known as valvulae convergentes. So this patient, so actually let me discuss what bowel obstruction is first. So quick tour. This is obviously the right of the patient, and this is the left of the patient. As I mentioned previously, laterality, the right of the screen is the left of the patient, and the left of the screen is the right of the patient. So this radiograph has been obtained when the patient was supine. So the patient is like this, and we've shone X-rays through whilst the patient's lying, and it's been detected by the detector on this other side of the patient. So if I were to tell you that all of these loops of bowel were abnormal, so if I were to say that I took all of these bowel loops out of the patient and made them into one straight line, what you'd be left with is you'd have, say, the mouth here, you have the esophagus, you have the stomach, you have the small bowel, and then you have the large bowel. And then the last thing you have is you have rectum here. Okay, so if I were to tell you that there was an obstructing point in the small bowel somewhere here, what would happen in this case is as the patient eats, more and more food and water, etc., are trying to get through, but there is an obstructing point here which stops anything from getting further. So what happens is the food, liquid, etc., that's trying to get through backs up, and as a result, the small bowel becomes bigger and bigger, more and more fluid and gas filled. This backs up to the stomach, which also gets bigger and bigger, and this causes the patient to vomit out. Hope that makes sense so far. So as a result, on imaging, what we can see is we will see multiple loops of dilated, centrally located small bowel, and we can diagnose this on radiographs. However, this patient would require a CT for further characterization, particularly to look for a cause of the small bowel obstruction. Free gas is known as pneumoperitoneum, and as I mentioned previously, gas will be black as most x-rays pass through. And on this radiograph, we can see this is gas. So this patient is actually standing up, and x-rays are passed through the patient with detectors behind the patient. So we have gas rising up and delineating our normal structures. So it's actually delineating the diaphragm, And this is our gas. All of this black stuff is our gas. We can see other normal anatomical structures around it. So all of this gas is actually displacing normal structures such as our liver, which I mentioned before, and other normal anatomical structures here. And so we have just talked about 2D imaging and x-rays in the setting of fluoroscopy and plain radiographs. So now we're going to move on to computed tomography. So what computed tomography or CT is, essentially CT scans also use x-rays to create a picture. So a patient lies down on a bed or table that passes through a CT scanner, and a rotating x-ray source and a detector spin around the outside of the patient, gathering data and sending this to a computer, which presents it as a series of slices or images. Once all of the data has been gathered, a computer then builds up all of the data and presents it to the radiologist as a series of images, which we can scroll through. Think of it as if you're looking from the foot of the patient. So this is what you'll see. So imagine this is the foot. So we're looking at the foot of the patient. And so the patient's face would be here. So we're looking up the patient. I'll show you, and it will make a bit more sense when I should take you through some CT images. So this is what an X-ray is. As we can see, this is what a CT is. We can see that this is, the T is our X-ray tube, which emits X-rays. X-rays are delineated by these red arrows, and then there are loads of detectors arranged in an array here. Loads and loads of detectors, and this whole apparatus rotates. Oops, let me get it better. It rotates around the patient as the patient actually moves through the scanner. So we'll have an X-ray source shining X-rays through an array of detectors on the other side, which actually just rotates around the patient as the patients move. Hope that makes sense. It can be very difficult to kind of get your head around this concept, but essentially what this does is it builds up slices of the patient in a 360-degree rotation. So just like our fluoroscopic swallow study, CT requires contrast agents to help us differentiate between different anatomical structures, for us to assess vasculature and so forth. We can give this via intravenous methods to allow normal anatomical structures to take up the contrast and shine slightly brighter. We can also use oral contrast agents, just like we did in fluoroscopy, so that we can image bowel and luminal structures in greater detail. Just like plain radiographs, we have densities in CT, and what CT images consist of are pixels, which vary in density depending on what the X-ray beams have had to pass through, whether it's air, fat, muscle, soft tissue, fluid, or bone. Whiter pixels, as I mentioned, are secondary dense substances which absorb more X-rays, such as bone and metal, and blacker pixels secondary to air, as I mentioned previously. So there are many advantages and disadvantages to CT. The advantages of CT is that it's an excellent imaging modality for soft tissues, organ, bowel, vasculature, bones, etc. It is quick and efficient. Most studies take a maximum of about 15 to 20 minutes. It provides rapid imaging in the acute patient in the setting of trauma, as well as in chronic conditions whereby follow-up imaging is vital, for example, in cancer staging. We also have a large quantity of information which we can siphon through to give an accurate diagnosis, and this is ever increasing as the years go by and as our CT technology improves. Disadvantages of CT is that it can give a high dose radiation to the patient, and so that should not be used in pregnant people and in children. I mean, it can be used, but it has to be used very sparingly and carefully. It is also expensive to purchase and maintain. So, if you remember, I talked about thinking about looking at the patient as if they were at the end of the bed. So imagine we're looking at the plantar aspect of the feet here, and they have gone into the scan like this. So we're looking like that. And so laterality is very important here. So the opposites are true. So right is on the left side of the screen and left is on the right side of the screen. And so what we have here is we have an axial section here and a coronal section here. And coronal is what you generally look at in your anatomical textbooks. And so the normal anatomical structures we can see on this coronal section is we've got the liver here, we've got the spleen here, we've got the stomach, and the stomach is bright as well as multiple loops of small bowel because this patient has been given oral contrast. The patient has also been given intravenous contrast, and you can see that because the abdominal aorta here is well opacified, as is the inferior vena cava. And so this intravenous contrast has actually gone into the liver, and the spleen has actually enhanced it, so it made it look a bit brighter. So if we took a section here, one slice, and looked at the coronal image here on the right, you can see that the liver looks like this on our axial section, the spleen looks like this, and actually on our axial section we have a better understanding of our anterior and posterior slices, posterior orientation. So posteriorly in the retroperitoneum we have our kidneys here, we have the aorta here, and we have some of the pancreas. We have, as I mentioned, spleen, we have our liver, and we have our stomach, which is full of contrast. Other things that we can see is we can see our vertebral body here, and we can see some ribs, but some ribs are kind of cut out, because if you imagine if we've cut through a slice of the patient, some ribs will be in view, some won't be in view. All of the ribs actually won't be in complete profile. So now what I'm going to do is I'm going to scroll through a normal CT of the abdomen and pelvis. This patient has been given IV contrast, and this is the aorta. This is the distal thoracic aorta. So I'm just going to go scroll through it properly, just slowly, and just see if you can identify any normal anatomical structures. I just want you to also remember that, and remember what I told you about laterality. So the right of the screen, which is here, represents the left of the patient, and the left of the screen represents the right of the patient. So the first thing that we notice on our screen is the lungs. So right at the top, our lungs are low in density as a result of them being filled with air. Other things that we notice are high density bones, as well as our ribs. And our ribs are not all in one plane, as they do not form a completely perfect horizontal line. And so we have to scroll up and down the ribs to actually be able to visualize the ribs in entire profile. So I'm scrolling, for example, if you have a look at this rib here, I'm just scrolling up and down the rib. This is the 12th rib on the right, so I'm just going to scroll up and down the rib so that we can actually appreciate the entirety of the rib. So here's that rib. Oh, actually, that was the 11th rib, sorry. So that's the 11th rib there. The 12th rib's just below. Right, so more of the abdominal structures that we are more interested in today. So the first thing I want to show you is the liver. So the liver will be on the right of the screen, and it's this large grey density structure. You can also see that there's a gallbladder around the gallbladder fossa, with just the inferior surface of the liver. Just if you don't see, so this is the liver that I'm talking about. and it's split into 8 segments, which we won't go into today. But what we can see of the liver, we can see that the IVC is here, and the hepatic veins will be coming like this. So your hepatic veins will be divided into the right, middle, and left. See if you can note them out when I scroll up and down. You may not, because the hepatic veins are not well opacified in this study. But see if you can notice things coming into this structure here. If you do notice them, those are the hepatic veins. So you can see all the way top, those are some white structures coming in. Those are your hepatic veins. The next thing is a portal vein. So the main portal vein is this. This is our main portal vein. And our main portal vein will divide into the right portal vein, which divides then into the right anterior and right posterior, and also divides into the left portal vein. So see if you can see all of that here. So I'm showing you the right anterior and posterior portal veins there. So if you can't see, the right posterior will be coming here and the right anterior will be coming there. And I'm just going to go and follow the left. So here is our left. So the left is going to be in that contour. So I'm just going to scroll again, just see if you can see that. Great. So that's your liver. I'm going to show you the normal pancreas now. So the pancreas will be around this area. So just keep your eye there. You'll see a soft tissue density structure, which is slightly grey, just coming in and out of view. So this is a nice representation of the pancreatic body and the pancreatic tail. You can see a vessel just posterior to the pancreas, and this is the splenic vein. So as you can probably already appreciate, we get a lot of nice anatomical detail with CT. Another thing I would like to show you is the spleen. As we saw in the previous imaging, here is our spleen. And so that's our HPB system. I would also want to show you the biliary system. When the biliary system is normal, we don't really assess it. When the biliary system is dilated, we can see it not assess it, we don't really see it. So if the biliary system is abnormal, it's dilated, then we can assess it a bit better. So we can see the thing that I'm looking at, this thing is our gallbladder, and it's fluid filled, and it's slightly brighter than the black fat. So all of this is subcutaneous fat, which is slightly darker, but slightly darker than soft tissue here. This is our muscle, paraspinal muscles, intra-abdominal fat, subcutaneous fat, etc. So now what we're going to do is, so we've gone through the liver, the gallbladder, the pancreas and spleen. So see if you can note them now. See if you can look at the IVC and the hepatic veins. Great. And the portal vein. Good. So now we can have a look at the kidneys. So look at the right kidney and the left kidney. I'm just going to scroll in and out of view. So out of view and back in view. Both kidneys look nice and normal symmetrically. And just above the kidneys, you should be able to see 2 adrenal glands. So your adrenal glands essentially are these kind of Y-shaped organs. And this one will also be like that. So just see if you can have a look at your left adrenal gland here. I'm just going to come in, just keep looking left. There we go. So there's our left adrenal gland here. Another thing that you may notice is that this patient has been given oral contrast in addition to IV contrast, and that's probably because we wanted to assess the normal GI tract. So what we have here initially is our stomach. And just following the stomach down, we can see that there are multiple loops of small bowel. So all of this is small bowel, small bowel, small bowel. So small bowel generally are centrally located. Conversely, large bowel would be peripherally located. And I will show you that now. So you can see small bowel has lots and lots of contrast in, and they're centrally located. But for example, this would be your large bowel loop, and the large bowel loop you'd follow up and down. So you can just follow that large bowel loop coming up. I'm sorry, that's probably incorrect now, but the large bowel loop is here. So the large bowel loop, that's just the descending colon on the left, and if you look at the right side, you have ascending colon just peripherally here. Good. And one more nice normal anatomical structure that I've just seen is our appendix. So here is our appendix to the right of the patient, this thing here. Let me just point to it. That's our appendix. So I'm just going to scroll up and down the appendix so that you have a bit of a better understanding of what the appendix looks like. You can see it's a blind ending tubular structure arising from the cecum. So it's coming from the cecum there, coming up, 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 and then ending here. Great. After this, because this will make more sense to you. So this is our coronal view. And so I'm just scrolling through all of the images just to give you a feel for what it looks like. And then I will speak you through. So we have the normal liver here. We have the main portal vein dividing into the right main portal vein here. We have a bit of our gallbladder here. We have our spleen here. And let me just remind you of our laterality. So left of the screen is right of the patient and right of the screen is left of the patient. We have our kidneys. We have our vertebral bodies. We have some of the pelvic bones here. And you can see this fluid-filled structure is our gallbladder. And I'm going to show you the stomach. So this is the fundus of the stomach. Body, and then we have the antrum here. So I'm just going to scroll through the stomach so that you can just appreciate it a bit better. Just going to scroll back and forth over the stomach. And then you can see loads and loads of loops of small bowel, which are normal in caliber and contain high density contrast material. And what we can also see here is our bladder, which we weren't able to see before. And if you follow the bladder up, we'll see our kidneys. The base of the lungs are also visualized here, which are black, as I mentioned previously. Black things are as a result of most x-rays passing through from the tube and into the detector, showing black, and the white things are things where, such as bone and contrast material, which block x-rays and thus appear white. So I'm just now going to show you an example of large bowel obstruction. If you remember, let me just explain a bit better. So we have our mouth, then we have our esophagus, then we have our stomach, then we have our small bowel, and then we have our large bowel, and then we have our rectum. So large bowel obstruction will be an obstruction at any part of the rectum. In the case below, I will show you an example of bowel obstruction at the level of around the sigmoid colon here. So what we can see here, if you remember, right is on left of the screen and left is on the right of the screen, so right and left. So we can see that there are multiple loops of dilated and gas-filled large bowel. We can see that they are large bowel, as you can see the Haustra markings here. If I were to play through this CT, which is in axial, we can see that we have multiple loops of really, really dilated large bowel. So this dimension is our really, really dilated large bowel, which contains fecalized material, but also contain gas. And as we scroll down, we can see that I'm going to start from the ascending colon here. So I'm going to go up, just rub all of this off. I'm going up now. So we're going up the patient, ascending colon. So ascending colon, just right of the screen, just left of the screen and right of the patient is our ascending colon. Just going down and then going up. Then we will hit our transverse colon here, and I'm going across, just follow that. We're going to hit our descending colon here. And I'm just going to follow the descending colon all the way down into the pelvis, and here we have what we remember as a transition point. So here the bowel is very thickened in the sigmoid colon, and it's causing the dilatation of all of the bowel proximal to this area of thickening. So if the thickening was here, it's causing dilatation of all of the bowel just proximal. And so this is a large bowel obstruction as a result of sigmoid pathology, and in this case it was sigmoid malignancy. And so this will be our last pathological example on CT. So what we have here is a coronal slice on the left of the screen and axial slice on the right. So so we can see again our liver here, spleen here, and we have normal anatomical structures. So we have our kidneys, aorta, IVC. We have normal bowel. So I'm just going to show you the appendix here. So this patient has acute appendicitis. So the appendix arises at the inferior aspect of the cecal pole. So imagine this is cecal pole. We have the terminal ileum just superior. So that's the terminal ileum. And we have our appendix, which arises just inferior at the cecal pole. And so everything above this will be the ascending colon. So if we look on the image to the left of the screen, we have here, so I'll just show you the appendix. This is our appendix, and it's dilated, thick-walled, and it contains high-density structures inside. And these high-density structures are appendicoliths, which have caused obstruction at the appendiceal origin. So the appendicoliths are actually present here, and it's caused obstruction to the appendix, and everything distal to this becomes fluid-filled and dilated. And so we can also see this on our axial images. So let me just show you there. So this is the appendicolith, and the appendix, if you just keep looking, will be coming out here. So I'm just going to slowly, it's coming out there. There's the appendix. Here's the appendix, and it's dilated, fluid-filled, and there's lots of mucky fat around it, which is seen by all of these strandy areas. And this is acute appendicitis. So now we've just talked about X-rays in the setting of fluoroscopy, plain radiographs, and CT, and we'll be now talking about ultrasonography or ultrasound. This is an imaging technique which uses high-frequency sound waves to characterize soft tissues. There is no radiation, and thus it's an ideal modality to image children and pregnant people. Essentially what you have is a probe or a transducer, which looks a bit like this, which sends high-frequency ultrasound pulses through the patient's body. It's inaudible and of high frequency. And different tissues within the body, just like in CT, different tissues will absorb these ultrasound waves or reflect these ultrasound waves to a different degree. So what you have is some ultrasound waves which pass through tissue, some ultrasound waves which are reflected back. And there are crystals inside this ultrasound probe which both emit ultrasound pulses and detect ultrasound pulses. And the detection of the reflected waves are then transformed into an electric signal, which is then made to use a 2D grayscale image. We can also use ultrasound to determine movement, especially in the setting of assessing vascular structures. So in the GI tract, it's mainly used to assess solid abdominal viscera, such as liver, gallbladder, pancreas, spleen, kidneys, and the urinary bladder. It can also be used to assess bowel, but artifact from gas, which reflects a lot of the sound waves, can preclude a full assessment. It is very well used in chronic as well as acute conditions, including assess Crohn's disease, as well as in aiding the diagnosis of appendicitis, particularly in children and pregnant people. And so this is an image, two images of a normal upper abdominal ultrasound. And so if we imagine the patient, so this is the patient's head, and this is the patient's neck, shoulders, arm, and then this is the body. So if we imagine our probe is orientated in this plane and our liver is sitting here, and our kidneys is sitting like this. Let's have a look at this picture and this picture. So this picture makes more sense, as if you imagine the ultrasound waves being emitted like this. We can see that the ultrasound waves are being emitted like this, with the ultrasound sitting here. And so the first thing that you'd see is the liver, which reflects some of the ultrasound waves back to the transducer. And then the second thing that you'd see is the kidney right here. And that's a similar picture here. So this is the liver and this is the kidney. And so these are other ultrasound images of the same patient. These are all normal examinations. So on here we have a normal kidney, and we measure the kidney in bipolar length. And as you can see, certain things about the kidney, the cortex of the kidney is slightly hypoechoic, which is slightly low in echoes, and the renal sinus here is high in it, which is called hyperechoic, which means high in echo signals. This generally just reflects how many ultrasounds are reflected back and how many actually just pass through. Here we have on the upper left, this is a gallbladder, and the gallbladder is full of fluid. And so what that means for ultrasound is, if we have our ultrasound probe up here, the ultrasound probe, so when it hits the liver, some of the waves are reflected back, but when it hits the gallbladder, a lot of the waves are just transmitted through, and it's facilitated through due to fluid. When ultrasound waves hit gas or bone, most of the waves are just reflected back, and none of them go through, and thus this produces a lot of artifact. And so bones and gas are not well visualized on ultrasound. The last image here, we have our spleen. So these are two separate images of the same patient. So it just looks slightly confusing, but these are two separate images. This is one image and this is a second image. And what we have here is an image of appendicitis. Now we can see that the proximal appendix here is normal. However, the distal appendix tip is grossly abnormal, and you can see that it's fluid filled. This image here is the same image in a different plane, and we can actually just see that the appendix tip is also dilated and fluid filled. As I mentioned before, fluid filled structures are generally black. MRI is the last imaging modality we're going to speak about today. I know time's running out, so I'll try to go through this as quickly as I can. So it's an imaging modality that does not use any ionizing radiation. MRI machines rather use a strong magnetic field instead of X-rays. A patient sits within a really large magnet, and actually it can be quite claustrophobic. It's like a tunnel, much like the CT, but it's much longer. Essentially, the images you require from an MRI is dependent upon the composition of different tissues and how they respond to a magnetic field. It is very useful to image soft tissue in tremendous detail, for example, muscle, ligaments, as well as the liver and brain are very well imaged on MRI. Sorry, I had a bit of word salad there. Bowel can also be imaged with great detail, and we can give different contrast agents to help with this. However, I must note that anything with air is poorly imaged on MR. So with regards to the GI system and abdominal system, the HPB or hepatopancreatobiliary system is best imaged with MRI, and it's very useful to characterize hepatic, pancreatic, and biliary lesions. Contrast agents here can also be used, such as gadolinium, which can help with characterization. And there are different weighted images which we use, which I won't go into as it can be very complex, to better characterize pathology. So this is a T2 weighted image of the HPB system in a patient. T2 is just how we've obtained the images. So on T2 we can see that there are bright things. So fluid in the CSF is bright, as you can see here. We can also see subcutaneous fat, which is bright, and intraabdominal fat, which is also bright. Darker things include muscle. This is the paraspinal muscles, and the liver is also relatively dark, as you can see. So our liver is here. We have our spleen here, and MRI essentially here is very, very useful in assessing certain lesions and characterizing them better. We can also see the pancreas in better detail around here. And again, very good for assessing the liver, the pancreas, and the spleen. Gallbladder pathology is also very readily characterized on MRI. MRI can also be used to further characterize kidney lesions, as well as bowel once we've given contrast, and actually this patient has been given contrast, but not to the extent that dedicated bowel imaging would require. So this is the last image that we're going to look at, and so this is a coronal MRI of the same patient that we saw, and this is T2 weighted image. As you can see, all of the fat, which we have subcutaneous fat, and the intra-abdominal fat, is all bright. I want to just show you the laterality again, as left of the screen represents the right of the patient, and right of the screen represents the left of the patient. And as I mentioned before, MRI is excellent to image soft tissue in greater detail, and in this particular case, we were imaging the HPB system, and we're able to characterize lesions much better. So in summary, there are a variety of imaging modalities used in the radiology department to help diagnose and help patients along their journeys. CT and plain films use ionizing radiation or X-rays to obtain images of the body, and is generally our workhorse forms of imaging. Ultrasound is a good alternative in a pregnant person or a child, and MRI gives us very good soft tissue definition and enables us to image different parts of the body. So I really hope that was useful. I know that it can be very complex, and I try to make it as simple as possible, showing you a lot of the anatomy. I know that some of the pathology I showed you could be slightly complex, but I think it's nice to have a look at pathology that you may come across in the next couple of years of your training. So if there's any questions, please don't hesitate to email me. My email's on the screen. And good luck on the rest of your year.